Good morning, everyone. Welcome to today's Talk with a Doc, all about Parkinson's disease. Thank you so much for taking the time to join us here virtually. My name is Brooke Oliveri. I'm the manager of the Long Island Health Collaborative. For those of you who may not know, the collaborative is overseen by the Nassau-Suffolk Hospital Council, and we are a group of 300 plus hospitals, health departments, community-based organizations, and other organizations really from all sectors working to improve the health of Long Islanders. Many thanks to our sponsor, AARP New York, and thank you so much to Dr. Guy Schwartz of Stony Brook Medicine for taking some time out of his busy day to educate us about today's topic, Parkinson's disease. So some housekeeping. This program will be recorded today, as you've been notified, and by participating, you are consenting to being part of this recording. We will have some poll questions before and after today's presentation, and we will have an interactive Q&A with Dr. Schwartz at the end of his presentation. So please hold your questions until the end, or feel free to put them in the chat in the meantime if you don't want to forget them, and I'll make sure that we get to all of those questions at the end. So I'd like to share a word about AARP. So on behalf of AARP, welcome to today's Healthy Talk with a Doc webinar. AARP is committed to helping you stay healthy and stay connected, so they congratulate you for taking the time to learn more with AARP and the Long Island Health Collaborative. AARP is a nonprofit, nonpartisan membership organization for people aged 50 and older. There are 38 million members nationally, approximately 2.5 million in New York State, and about 500,000 living on Long Island alone. AARP works to strengthen age-friendly communities and make for happier, healthier residents of all ages, and they advocate for what matters most to people 50 and over and their families, with a focus on health security, financial stability, and personal fulfillment. So you can learn more about their other online classes, events, local discounts, volunteer opportunities, and more at aarp.org/nearyou. So before I continue, I do just want to make sure, by a show of hands, or could someone let me know, can you see the slides currently on the screen that say, Gary, is that a yes? Okay, excellent. Sorry, I just wanted to make sure. Okay. So now we are going to ask you just a few pre-event poll questions, if you wouldn't mind giving us some feedback. I'm going to go ahead and launch those right now. And just to let you know, we take these polls to gauge our attendees' impressions of our topic and their readiness to make lifestyle changes before and after the program. So you might be thinking to yourself, I don't know how ready I am to adopt some of these tips because I don't know what they are yet, but we want to gauge your impressions before and after. So if you wouldn't mind taking a moment to answer these 6 questions, we would very much appreciate it. And I'll just give it a moment or two here to allow everyone to read them and have a moment to respond. And I do see some responses coming in. Thank you so much for your feedback. We really, really appreciate it. And it really helps us to get to know you better and to tailor our programming to better fit your needs. So thank you. Going to give it maybe 20 more seconds, maybe 30. And I will introduce Dr. Schwartz. Okay. So I believe everyone has answered. So thank you very much again for this feedback. It is really important to us. I'm going to go ahead and close the poll now. And okay, so thank you for your feedback. And I would like to now introduce Dr. Guy Schwartz. He is our featured speaker today, and he is the director of Stony Brook's Parkinson's and Movement Disorder Center. He is trained to treat all neurological disorders, board certified in neurology. He has special clinical interests in neurological movement disorders, such as Parkinson's and Huntington's disease. Dr. Schwartz provides expert diagnosis and treatment for patients who suffer from movement disorder as co-director of the Movement Disorder Center at Stony Brook. And I understand that some of you already know Dr. Schwartz, so I'm sure you're just as excited to hear from him as I am. So without further ado, Dr. Schwartz, please take it away.
All right. First of all, Brooke, thank you for the invitation, and it's nice to see familiar names and faces. I hope that you'll find this topic interesting. This is something that I decided to talk about, risk factors, because this is something that commonly comes up in the office. A question patients and family have: what can I do to change the outcome of my disease? What risks are out there that I should be aware of? So I thought to give a summary on what we know. And this is a rather complex issue. I tried to make it simple because it's a hot area in science, specifically in this disease, and trying to sort out what really is a risk factor and what is a cause. So they're numerous. I decided to group them together into genetic, environmental, metabolic, and medical disorders that are risk factors or predict the later onset of Parkinson's disease. Now, our understanding is that not a single one of these is sufficient to cause or to place someone at high risk for Parkinson's disease. There are probably two or more factors, what we call the dual hit theory, that result that places someone at a high risk. And first, so before speaking about these, I'd like to clarify the difference between cause, risk factor, and association. And these are some examples that I came up with. And this is important because oftentimes, what I see in the media or the kind of feedback that I get from patients is that there's something reported in the news. I remember years ago, it was ibuprofen or calcium channel blocker. There was a lot of excitement that taking a calcium channel blocker, for example, will prevent Parkinson's from getting worse. But I always warn that these studies, the outcome of these studies are a result of large epidemiologic studies across multiple centers oftentimes, or national health registries in Europe, where populations in the millions are captured in one electronic medical record system that's then facilitates statistics of large at this scale to try to find out if there's an association or a relation between Parkinson's disease and something else. So I warn about these findings because they don't always translate to something practical that that's ready for clinical medicine as a recommendation for treatment. And here are some examples. So when we talk about cause in medicine, we mean that there's a direct cause and effect. For example, inhaling COVID-19 causes pneumonia. But there are some risk factors, not causes, but some risk factors, specifically diseases that cause atherosclerosis, so some change in the blood vessels, that places one at a high risk of serious complications from COVID-19. And that's diabetes and obesity over here. And then there's an association. So cause is it's the strongest relation between some kind of an insult and disease. A risk factor we identify as a kind of an indirect cause of a disease, whereas in association, we don't know whether it's direct, indirect, or where exactly the relationship. It could be a few steps down the line, whereby having a blood type O, which by the way is protective for COVID-19, not only is there lower incidence of infection, but also lower incidence of serious disease. We don't know it. It may have nothing to do with blood type O, but something downstream to it. So this is an example of cause, risk factor, and association. Another one is formaldehyde. It's known to cause cancer. That's a cause and effect. But what about risk factors? Living with someone who smokes, that is secondhand smoking, is a risk factor for developing. And what about smoking in general? Not every molecule makeup of smoking, what's in a cigarette, will cause cancer. It's really just formaldehyde and perhaps a few others that are carcinogenic. So, and another example is genetic mutation. So the BRCA, for example, BRCA gene causes breast cancer. Risk factor for prostate cancer is advanced age. So 90% of men who reach age 90 will develop prostate cancer. It's very prevalent, and the incidence goes up with age. But what about alcohol consumption and its association with bladder cancer? No clear cause and effect there. That one hasn't been fully parsed out, and we call it an association. It's really the loosest observation of two coincidental or incidental occurrences. So I hope that's clear, and I'll pause here for any questions, because this is not only semantics. In science, it matters a great deal. So I'll start by talking about genetics, and here's a series of genes that make up that have been associated, and some of them are causal. We know that you have this gene, it's directly will cause Parkinson's disease. For example, the LRRK2 mutation is strongly is a cause of Parkinson's disease, whereas the gene for Gaucher's disease, these individuals who don't have Gaucher's disease, they just carry the genetic mutation or variant of it. That is a loose association with Parkinson's disease. It's known not to cause the disease, but somewhere 2-3 steps downstream may cause some effect, some metabolic or genetic effect that leads to Parkinson's disease. We don't know what it is. So over here on the x-axis, I don't know if everyone can see my the mouse, my cursor. These are genes associated with Parkinson's disease that are very common in the population. But their likelihood of causing disease is small. On the other hand, this is a group of genetic mutations that are very rare, but if you have one of those, there's a high likelihood of developing Parkinson's disease. So as you see, genes are complex. Oh, and I would add to this is my own addition to this, that having a Y chromosome places you at a higher risk of Parkinson's disease, because we know that it's more common in male than women, in men than women, male than females. So that alone, I think, maybe is the strongest driver of Parkinson's disease, is a predisposition to or being a male. So what I'm trying to say is that genes don't work linear. In other words, it's not as if some genes do, but occur in such a way that in every generation there's an individual with a certain disease, and it splits roughly 50-50. I took this diagram here to show that this is 4 generations, right? Great-grandparent and great children. But you see here that there's the squares are men, the circles are women, and that this the couple, the great-grandparents had 4 children, female, male, female. One of them developed Parkinson's disease, like her dad. One of them is a carrier, didn't develop Parkinson's disease. Now the grandmother who went on to develop Parkinson's disease had no children with the disease. It skipped a generation, but one of her sons had his own son with Parkinson's disease, and another child is a carrier. The same thing here. Here there are 2 generations where there's no one with Parkinson's disease, but because of this grandparent, this genetic mutation was inherited and appeared 4 generations later. So this is the complexity of genetic, and that's something that I'm asked. If I have Parkinson's disease, right? If I'm this person, what's the likelihood that one of my children will have Parkinson's disease? And the answer is often it's complex. It's possible that none of them will have. It's unlikely that all of them will have, or that a proportion will have. We do know that if you have a first-degree relative with Parkinson's disease, an individual is 3 times more likely to develop Parkinson's disease. What about environmental? Now, this we've known for a long time. We know that in Americans living in rural regions who work in farming, and sole source of water is well water, these individuals have a higher incidence of Parkinson's disease. And So these observations, it's been narrowed down that there's a common denominator here, that's the pesticides specifically, or a class of pesticides called organophosphates, and this one in particular. Trichloroethylene, previously widely used, and in the US slowly restricted in its use by the FDA. But it's still present in chemical removers of stains, whether it's clothing, carpet stains, paint, and grease. It's also present in adhesive, certain cleaning wipes and aerosols. It's also a refrigerant. What about infections? Influenza has been discussed, and we know in the large Parkinson's disease pandemic around shortly before and during World War I, there was a spike in incidence of individuals with Parkinson's disease. It wasn't known at the time, but we've later learned that influenza was one of the, may have been the main cause. As far as COVID-19, there's never been found, to my knowledge, any association with Parkinson's disease. Metabolic, and I group these largely into drugs or habits that in some way change proteins, chemical makeups of the body, and this is a broad category as far as increased risks of resulting in Parkinson's disease. Use of beta blockers. These medications are used to control heart rate and blood pressure. Having low uric acid. Uric acid is it's not exactly a protein. It's closer to a protein than an amino acid. Is an oligomer, if I'm not mistaken. And this oligomer is involved in controlling, or in some form, its role is in the immune system, and having low levels of it predisposes to inflammation. And we're starting to believe, actually, there's now good data over the past 10 years. There's been accumulating data that Parkinson's disease is an inflammatory disease of the brain, a smoldering inflammation, not like we see, for example, in multiple sclerosis, which is an overt inflammatory disease. Also, years ago, a chemotherapeutic drug for treatment of leukemia was shown to have treatment with this drug was shown to have an association. I'm sorry, I have this in the wrong column. I just realized this. This chemotherapeutic drug belongs with a decreased risk of Parkinson's disease, along with another drug that suppresses the immune system, and that's ibuprofen. I don't know if everyone thinks of these non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. These drugs suppress the immune system very, very mildly, but that's the reason they are so effective in reducing inflammation of a cold or reducing fever. Other predispositions to, or whether consumed, other things that are consumed that are associated with a decreased risk of Parkinson's are calcium channel blockers, smoking, caffeine, and alcohol. And when I read this, I reflected on my patients, and I can't think of, I went a little bit puzzled, because I don't have that many patients who smoke tobacco. But you have to know that these studies were, again, large epidemiological studies looking at hundreds, if not thousands, of individuals. And it may just be in our region the incidence of smoking is low, where this is set off by other regions of the states. And these are all studies where the incidence is higher. This is a summary. I know it's a very loaded diagram, and it does speak to the two-hit theory that I mentioned, that there's some kind of a genetic predisposition, and they're numerous, and then a second insult of some sort, something that we consume, contract, or inhale, which sets off the disease process that eventually leads to what we know as Parkinson's disease. So there are a few medical conditions that are precursors to Parkinson's disease. We know that individuals with these conditions have a certain increased risk of going on to develop Parkinson's disease. And one of them, the one that appears the earliest, is constipation. This can appear 30 years before the onset of Parkinson's disease. Where we would define it as a bowel movement of less than every other day. So if you have a bowel movement once every 3 days, that would be qualify as constipation. But it's not constipation, although prevalent in Parkinson's disease. It's not specific. In other words, there could be constipation from numerous other causes, which I listed them here. Diet, lack of physical activity, pelvic floor dysfunction. So if you've had any prostate surgery, or if you've had children by vaginal surgery, there's a chance that you'll have pelvic floor weakening that predisposes to things like constipation. And then certain diseases like underactive thyroid, irritable bowel syndrome, and 15% of the time we don't know. It's unknown. The one drug that has been studied for the constipation in Parkinson's disease is Miralax. But there haven't been any rigorous head-to-head or clinical trials to tell us how to treat constipation Parkinson's disease. It's somewhat tailored to an individual. Sweat dysregulation. So we see there's a typical rash in Parkinson's disease called seborrheic dermatitis, and can predate the onset of Parkinson's disease. And we think it has to do with loss of normal sweat regulation. They also have to do something with cold limbs. Patients with Parkinson's can describe either coldness of their hands or sometimes just one side of the body. Low blood pressure. It's not unusual for someone in the years prior to developing the physical symptoms of Parkinson's disease of having low blood pressure. In fact, the low blood pressure in Parkinson's disease we think is protective of heart disease. And of course, there are other causes of blood pressure, low blood pressure, and iatrogenic, what we call medical induced. So in this case, medications. Athletes have low blood pressure, and those who abstain from high salt diets also run pressure on the low side. When it is low, and by the way, individuals with Parkinson's disease can live at a low blood pressure of, say, 80 systolic, so the upper number 80. And my staff, sometimes they get nervous when a patient comes in and they check the vitals, and they come frantically to my exam room and say, so-and-so has a blood pressure of 80. And my first question is, how does she feel? Is she dizzy? Is she complaining of feeling unwell? And the answer is no. And it's because some people with Parkinson's live at a very low blood pressure. Their autonomic nervous system has adjusted. But when it is high, when it does cause symptoms, when the level is such that upon standing, individuals develop lightheadedness, dizziness, and sometimes in extreme cases fainting, we recommend the strategies to reduce medications to lower blood pressure, increase salt intake, wear pressure stockings, and perform ankle pumps. So it's kind of a up and down movement of the ankle to improve circulation of venous blood to the heart. As far as medications, we have one FDA-approved drug called droxidopa, as well as 2 older ones, which have been used off-label for many years. This is called proamine and Florinef. Lastly, sleep phenomena, what we call a sleep parasomnia, an abnormal sleep condition by the name of REM sleep behavior disorder, or RBD, can predate the onset of Parkinson's disease by about 10 years, approximately 10 years. And it's highly, unlike the other ones that I mentioned, and I left out, by the way, diminished sense of smell. That's also a fairly consistent precursor of Parkinson's disease, or if you want to think of it, a risk factor. Just like loss of sense of smell, REM sleep behavior disorder, highly specific to Parkinson's disease, but not exclusively. In other words, we see RBD in other diseases, things like narcolepsy, or assisted disease to Parkinson's disease, we call multiple system atrophy. And it manifests with acting out of dreams. And individual with Parkinson's disease can describe quite vivid dreams. And acting out of dreams sometimes are pleasant, but other times it can be in the setting of a nightmare. So fighting off villains, protecting the family, running away from chasing animals. This is a video clip of an individual who I think was having response to such a nightmare. You'll see here. And okay, so this is very typical. It is a deliberate or a seemingly deliberate movements in response to a dream content. They're oftentimes benign. Their major risk is in striking of the bedmate, and the risk to self is injury when falling out of bed. So what I recommend in these situations is to make the bed environment safe, to move away any sharp furniture or night lights or anything that, and to pad the bed, so putting down a rug as opposed to just a hardwood floor, and to put some pillows or other barriers in place to protect the bedmate. Now, the two drugs that I mentioned, that I listed here, are not don't have an FDA label for the treatment of RBD, but we use them commonly because of small studies that show their benefit. That is all I have to say about the risks and associations with Parkinson's disease. I'll take any questions. If there are any.
I have a question. Dr. Schwartz, well, firstly, thank you so much. Everything you shared was so informative, and I didn't know any of that as someone who loves someone who lives with Parkinson's disease, so thank you so much. I do want to ask, are there any things that people who might be predisposed to Parkinson's disease or might have it can do in their daily lives to mitigate some of the symptoms that they might be experiencing?
So mitigate symptoms. So these individuals prevent the onset of later Parkinson's disease, or
I guess I was asking both.
Symptoms. Okay.
Let's go with deal with symptoms. Okay, those who have it.
Yeah. So I would say, okay. It's kind of, I guess my answers will cover both, or pre-symptomatic, or individuals who are at risk or destined to develop Parkinson's if they lived old enough, and those with the disease, is avoiding certain things that we can that are known to be toxic. Obviously, you can't. There's some things here that are unavoidable, right? The influenza, for example. There are some lifestyle changes that you can, some things that you can avoid contact with. Obviously, we don't choose our parents, so we have no control over our genes. But I would say, and I know for those of you who speak to me at the office, I'm a big proponent of aerobic exercise, whether you're in the clinical stage of Parkinson's, in other words, you've developed the disease, or whether you're at risk for Parkinson's disease because of a family member, for example, or you know that you carry a certain genetic mutation associated with the disease or known to cause the disease. Aerobic exercise is uniformly advisable, not just when it comes to neurodegenerative diseases, but also it's cardioprotective. Cardiologists are recommending it half an hour a day, at least 3 days a week. I recommend, if you're going to do that, work up slowly to half an hour a day. And if you can incorporate it into a daily routine, that's great. I'm going to sound like a broken record to some of you, but I like the stationary bicycle. You don't need a membership. You can do it year-round, even in inclement weather, on your own time, in your own home. But what I recommend to my patients to do whatever they enjoy, whatever aerobic exercise they're doing or they're enjoying. And the other thing is diet. And
This is because this is getting more attention. And this is a talk for another day. I'm happy to be invited back to talk about diet and how our gut, the bacteria, other inhabitants of our colon affect disease. There is something there, something valid, hasn't been worked out, but there is something about diet, population of bacterium in the colon and disease process. We don't know the cause effect or associations yet, but just that there's a problem there. We know this because individuals with Parkinson's disease, when we examine their fecal matter, we see that the population of bacteria that they carry in their gut is different than individuals who don't have Parkinson's disease. The milieu, the environment of bacteria is different. Bacteria are important, by the way. Bacteria in the gut are part of who we are. We live with them symbiotically. So in that vein, I would say a Mediterranean diet. That is the best we can do, and there's some data to show its benefit in Parkinson's disease.
That's fascinating about the gut bacteria, and thank you for those tips. If anyone else has any questions, please feel free to unmute yourself or put it in the chat if you'd prefer. In the meantime, while I think Gary might have a question.
Yeah, hi, Dr. Schwartz. I'm very curious, what do you mean when you say increased risk versus decreased risks? What does decreased risks mean?
Sure, sure. Yeah, let me see here.
I mean, does it mean, I know you don't mean this, but does it mean that you should drink more coffee or you should not worry about smoking regarding Parkinson's? I mean, I'm just not sure what that means.
Sure. First of all, for the record, I do not recommend smoking. If there is benefit for Parkinson's, we don't quite know. So that's a tenuous relationship, but the relationship between smoking and cancer is well established.
Right, right.
By all means, avoid it. And I would say, so for example, I think that the latest two have been ibuprofen and uric acid. And these were established. Some of these were studied in the Veterans Affairs, which is America's version of National Health System. Right, the British have these registries. So do the Germans. A lot of socialized countries where there's socialized medicine. There's one electronic system that captures all the population. And then they can use analytics and say, we're going to narrow down to those individuals in our country who have Parkinson's disease. And we're going to ask a question: how many do those use ibuprofen? And we're going to compare those to a similar population, similar in age, similar in gender. We're going to look for what is the incidence of their use of ibuprofen. And what was shown is that in those without Parkinson's disease, there was more use of ibuprofen. So the thing is, well, does it mean so? Why? So that always raises a question: what is it about ibuprofen? It's obviously not the people, because the people were random. They just took random people, those with Parkinson's, those without. They didn't select them in any way, just because the number of individuals is so big that whatever differences they are, say incidence of diabetes, for example, was saturated out. You look at thousands of patients just by random chance. A lot of you can be assured that a lot of differences between them, a lot of conditions between them would be similar. But then if you're interested in a specific parameter, let's say I want to know the use of ibuprofen between those two conditions, you have to look for it. You have to define in your algorithm, tell me among the English population, what is the incidence of ibuprofen in those two. And that's where it was shown that taking ibuprofen is quote unquote protective. In other words, if you take ibuprofen, you're more likely to be in the group that doesn't have Parkinson's disease than the group that go on to develop Parkinson's disease. What is it about ibuprofen? We don't know. Is it because it's an anti-inflammatory, and we know that in Parkinson's disease, there is inflammation of the brain, so that chronic use of an anti-inflammatory for decades will suppress this inflammation of the brain? We don't really know. I would say at this point, it's more of an association than a clear cause and effect.
Very interesting. Yeah. So someday it's possible that ibuprofen could be used as a preventative medication.
Or allow us to understand, well, what's common between ibuprofen here? I don't know if you can see my mouse, uric acid and chemotherapeutic drugs. They all suppress the immune system. Maybe attention should be focused for researchers, not how to promote ibuprofen or one drug or another that suppresses the immune system, but find one treatment that suppresses the immune system that is both safe and effective and can be used long term in preventing and slowing down progression. Whether it'll turn out to be ibuprofen or another drug that's available in the market or something developing, that will remain to be seen. Ibuprofen is not benign. I don't recommend taking it daily. In general, these anti-inflammatory drugs here are associated with gastrointestinal bleeding and chronic renal failure. So one of the common causes of the individuals going to hemodialysis, if they're abused, if they take it from extended periods of time in high doses, they can develop permanent renal failure. So I would say these observations should make us think of, certainly the clinician, I'm not going to make the leap and say, take this, it will in some way slow down your progression. What it allows me to understand is that interfering in some form with the immune system and reducing it, revving it down somewhat, may affect how kind of the underlying biologic linchpin of this disease, that the inflammation may be a significant factor, and interfering with it in some way has beneficial effect. So I would place these as associations, and I go back to that first slide, right? As physicians, clinicians, scientists, we like this, right? At best, this, but definitely this is not enough for us to make reliable medical recommendations. Maybe with some exception. Don't smoke, because you cannot separate the formaldehyde from everything else in the cigarette.
That's pretty evergreen advice, right? Francis, did you have a question?
Yeah, I did. I do. Two questions, actually. What are the chances of my son getting Parkinson's or my grandchildren getting Parkinson's?
Sure. So let's assume for a moment, Francis, that you carry one of these genetic mutations. Say it's one of these common mutations here, and let's take your son. If he inherits the same mutation, he has this mutation is known to have a very small risk of developing Parkinson's disease. You had the misfortune of being one of those the rare individual who developed Parkinson's disease, but another individual who inherits the same first-degree relative may not develop it. And this is here on my side. I can see the graph as well. Let me just change how the layout here.
He was actually concerned about that.
Understandably, as I mentioned, for individuals who have a first-degree relative with Parkinson's disease, there is an increased risk, because in part, in 15% of the time, it is inherited. But what I'm trying to show also, you mentioned your grandson. So say you are this generation here, and there's a chance that your son will never develop an inherited form of Parkinson's disease, hypothetically speaking. Let's say you do have the hereditary form, nor will the third generation, his children. It's possible that it will appear in the fourth generation.
Wow. Okay.
So certainly, it's considering what we know about the genetics of Parkinson's disease. I kind of empathize and want to validate that there is an increased risk, but there's a very good chance that he'll never develop it.
Is it worth him getting the genetic testing?
There are some that are commercially available. These two I know. Some of them are identified in laboratories, so there is no company that provides this test to the public. So we cannot test for them unless you're part of a research study in a lab where this study where they're looking for volunteers. Part of a study to test for these. And some are commercially available, and you can have them tested. It's usually just a swab, just a mouth swab of saliva, which in our saliva there are cells, and all we need is a few cells that carry our DNA to do a genetic analysis. To the question, because Parkinson's disease is not a curable disease, and there's no specific recommendation that I can say, do this and you'll avoid getting Parkinson's disease, other than the two broad general recommendations that I made, but exercise and diet. Some people don't wish to know because really it's not curable, and there's no strong, reliable data that it's preventable. I recommend whether an individual has a risk factor for Parkinson's disease or not to do those two interventions, diet and exercise. But some people don't want to carry the burden of knowing that they have a genetic mutation that at some time later in life they'll develop. There's
Right.
some probability that they'll develop the disease. That's true for a lot of the genetic diseases for which we don't have treatment. The one that I also treat and have interest in is Huntington's disease, which is strongly genetic. And it's interesting in those who are at risk. So those individuals who have a first-degree relative with Huntington's disease have a 50% chance of developing at some point in their life. But studies have shown that only 5% of such individuals, so these individuals who don't have the disease but are at high risk of developing, only 5% of those choose to be tested. Because of the psychological burden that comes with knowing that you carry a genetic mutation that is out of your control and out of your physicians in preventing disease onset. So definitely it's commercially available. I always have this discussion with my patients, and if there are relatives in the room who were interested about this topic, that's how I present it, and more in depth. Obviously, specific to an individual.
Thank you
Second
so much.
question.
Oh,
One more question. What's causing, I tend to lean now a lot towards the left. When I'm standing doing dishes, if I'm sitting in the chair, my body just tends to just go to the left.
Yes, Cheryl made me aware. Let's talk about this offline.
Okay.
I don't
Got
give
it.
specific recommendations, and you may not want me to do it. Some things are private, but we can talk about it outside of this talk.
That's a deal.
I see Susan has her hand raised, and I think Robert might have a question after her. So Susan, what is your question?
Oh, hi. I wanted to ask about the diet. I've been on, for close to 20 years now, whole food plant-based diet. So I have a lot of fiber. I lost my sense of smell in 2012, but I've never been constipated. I eat a lot of beans and a lot of cruciferous vegetables. So I wonder if when you recommend Mediterranean, should I be putting in some fish or, something else, or am I okay with?
That's a good question. I commend you, first of all. I live with a vegan, and we've raised our son, certainly in his first 4 or 5 years, as an ovo-lacto vegetarian, and I ascribe to that. I also restrict my diet, so I'm with you and support it. There's never been. I would have to research it. I don't know about vegan, vegetarian as compared to Mediterranean diet. Mediterranean diet has received a lot of attention because of strong correlation with Alzheimer's disease, and some of it has been extrapolated to Parkinson's disease. but I do wonder whether even more increasingly plant-based has a better prognosis. Oncologists are recommending vegan diets for individuals with colon cancer. So definitely there's some benefit in plant-based diet. I think we don't know. I think, unfortunately, physicians, scientists, there's not a lot of interest, and unfortunately, there is unfortunately a lot of interest and enthusiasm about diet and disease. It does come up periodically, but I think there's more to it than what's been already published and talked about. Vegan diet is not, has its shortcomings, right? Some of the food is processed, whether it's tofu or the Beyond Burger and things like that. So it's not completely benign. And beans are natural, right? Can't go wrong with that. But some of the processed food in vegan, some of the processed vegan food may not be that healthy. So
Yeah,
really,
I know you can eat Diet Coke and potato chips and be vegan, so but I try not to do that.
Yeah.
But anyhow, but I will say, my dad was never diagnosed with Parkinson's, and he smoked, like from the Korean War, he smoked 3 packs a day, and I'm sure now that he had undiagnosed Parkinson's. So the smoking, I don't think is it's a safeguard for sure, not in his case. But,
no, but again,
but he had horrible constipation, terrible. So.
You have to remember, again, these studies are large epidemiological studies that captures a big swath of the population, right? And again, I think it's certainly still true. I think in especially Southern Europe, smoking is much more prevalent than in the U.S. There's been a big move. I remember I was in high school, big move away from smoking. But yeah, I agree. I mean, it seems to be. And it may even be what smoking brand you smoke. There may be some that are more toxic than others. It's an observation, I would say. Don't smoke. It's interesting. We haven't quite figured out why, but I believe that there was a recent study in Scandinavia that challenged this observation. It's hard. It's hard with these large studies. It's hard to replicate these in the lab, but that's these observations where kind of research ideas take off from, right? Large observation, but most of the time it's hard to prove these, and that's why there remain observations for a very long time.
Very thought-provoking.
Well, I would just like to say I'd really welcome if you came back and did the gut connection. That would be really interesting.
Sure.
Thank you.
You hear that, Brooke?
Loud and clear.
Next cycle.
I think we have time for 2 more questions. Robert, if you have one, and then Jackie will take yours. Maybe I was incorrect about Robert having a question. So Jackie, if you'd like to ask your question.
Yeah, so I'm not Jackie, I'm her husband, Alan.
Hello, Alan.
So recently, my aging father, 83-year-old father, and his wife have moved in our home with us. And so I'm watching this basically because I have concerns with him. His wife does complain about him sometimes having violent stuff at night. When he's sleeping, he will punch or kick. The other thing I've noticed as I try to get him to walk with me is that he'll walk. He walks fine with his legs, but he often walks with his arms slightly in front of him and out straight. And I'm just wondering if that's some of the early signs I should be watching for.
So there are numerous causes of individuals in advanced age who develop problems walking. Could be neuropathy, could be lower spine disease, could be arthritic, knee, hip. So I would say that's not specific. That alone I wouldn't associate with disease unless I had a chance to examine the patient, right? As neurologists, we look at the manner or the pattern in which people walked as part of the neurologic examination. Those with Parkinson's disease have a very unique way of walking. Typically diminished arm swing, slightly stooped posture, but these are not specific. On the other hand, what sounds like RBD, this acting out of dreams, does correlate with Parkinson's disease, and there are not that many causes, not that many diseases that that correlate with it.
Got it.
Yeah, these can predate. If it's truly RBD, there are other things that can happen in sleep that can mimic RBD, seizures, for example, but they're not purposeful. There's no kind of seemingly deliberate purposeful movement there. It's more kind of a clenching or jerking, or something called periodic leg movements of sleep. And this is kind of an up and down movement of the feet during sleep. So again, I wouldn't make a diagnosis just based on what you're telling me, but if truly RBD, that does correlate with Parkinson's disease.
Gotcha.
I would say out of all the causes, out of all diseases in which we see RBD, Parkinson's is the most common, simply because it's much more common than the other one. And in our RBD, there's a high incidence of it.
All right. Well, thank you very much.
Thank you all for your questions, and thank you, Dr. Schwartz, for your very thorough answers. I am just going to share a few tips that we have about walking safely. As Dr. Schwartz mentioned, aerobic exercise is a great way for us to, combat some of those chronic diseases like Parkinson's. And as you might know, New York State, Long Island specifically, has some of the highest incidence of pedestrian injury and fatality. So while we're encouraging you to get out there and walk, we just want to remind you to always use the sidewalk. If there's no sidewalk, always walk facing traffic. Try to make eye contact with drivers when you can. Make sure to see and be seen. Wear brightly colored clothing. Carry a flashlight when walking at night. And cross streets at corners or in crosswalks. Don't text or talk on your cell phone while you're walking. It can be just as dangerous as doing that while driving. And for more information, you can visit walksafeli.org. And now I will launch those post-event, poll questions that I mentioned earlier. If you wouldn't mind just giving us some final feedback to close out the program, we would very much appreciate that.
Okay, thank you everyone for having me.
Thank you so much, Dr. Schwartz.
Bye-bye.
Thank you.
And thank you to everyone who participated and spent your morning with us. We really appreciate it.
Thank you, Brooke.
And thank you for answering these questions.
Thank you.
Thank you very much.
Thank you very much for putting this on. Thank you, Dr. Schwartz.
And while you're finishing up those questions, I will just remind you we have some other talks coming up this month. Actually, next month, we'll have 2 in May, 2 in June, and then we have these 3 in-person walking events at the end of each month. Our first one is actually this coming Saturday in Babylon's Argyle Park at 11 a.m. It is supposed to be a little bit rainy, so we'll see if we get to walk, but hopefully better weather for the other walks we have scheduled, and we hope to see you there. So I am going to close out the poll. Thank you everyone for your responses, and thank you for your time this morning. Everyone have a great afternoon.
Thank you very much.
Thank you.
So long.